Welcome to this video on anterior cranial fossa CSF leaks. Before we begin, consider the following questions. How do patients with spontaneous CSF leaks present? What are the key aspects of your clinical examination? How would you investigate a patient with suspected CSF leak? And what are the principles of treatment? CSF leaks of the anterior cranial fossa can be iatrogenic, traumatic, or spontaneous. Spontaneous CSF leaks are typically seen in a patient population at risk of idiopathic intracranial hypertension. That is to say, these are patients who are clinically overweight, middle-aged, and more frequently female than male. Patients may report unilateral clear rhinorrhea, which may have a salty taste. This can be exacerbated by bending over or by maneuvers that increase intracranial pressure, such as Valsalva maneuvers. Taking clinical history, it is also important to rule out other causes of clear rhinorrhea, such as allergic or vasomotor rhinitis. It's also important to inquire about any sequelae of idiopathic intracranial hypertension, such as visual changes or headaches. The aims of the clinical examination are to assess for the site of a leak, to assess for any complications of idiopathic intracranial hypertension, and to rule out an alternative diagnosis. Otoscopy should be performed to rule out a middle cranial fossa CSF leak, which may pass through the eustachian tube and cause rhinorrhea. Nasal endoscopy with a 30-degree endoscope should be performed, paying particular attention to the cribriform plate and the sphenoethmoidal recesses, looking for any visible flow of clear fluid in these areas. Examination should also look for any rhinitis or nasal polyposis which could be driving the rhinorrhea. Finally, ophthalmoscopy should be performed to look for papilledema, which is a hard sign of IIH. Diagnosis can be confirmed via collection and assay of the fluid. Presence of beta-2 transferrin or beta trace protein within the fluid confirms CSF. Radiological studies can also identify the site of the CSF leak. A high-resolution non-contrast CT scan can provide direct confirmation of the site of the skull base breach. These are most commonly seen either in or around the cribriform plate or at the lateral aspect of the sphenoid sinus in an area known as Sternberg's canal. Indirect signs which can be seen on a CT include thinning or scalloping of the skull base or an empty cellar, both of which suggest an elevated intracranial pressure. An MRI of the skull base can also be considered to rule out meningoencephalocele on T2 weighted images and also to confirm an empty cellar. In situations where fluid cannot be obtained for laboratory assay and where CT has not demonstrated an obvious site of the CSF leak, a cysternography can be performed. This involves a lumbar puncture along with injection of a radio-opaque contrast intrathecally, followed by a CT to look for flow of the tracer through the skull base. While performing the lumbar puncture, it's quite useful to note the opening pressure, which is elevated in cases of IIH. The main objective of treatment is to prevent ascending meningitis, and so patients should be treated expediently, though it is not an emergency. Prophylactic antibiotics are not usually used, particularly as these can mask early meningism. Surgical management is multidisciplinary and should be performed in a site where there is co-located neurosurgical services and appropriate post-procedural care. Involvement of other colleagues from the multidisciplinary team, including ophthalmology and dietetics, is also important. Ophthalmology can assess for any visual complications of IIH, and dietetic input is useful to help the patient lose weight and thus reduce their intracranial pressure. The surgical approach depends upon the size and the site of the leak. According to Verk and Saleh, for small defects, less than 4 mm, a simple fat plug or mucosal flap harvested either from the inferior turbinate, nasal floor or septum can be used to cover the defect. For defects between 4 and 10 mm, a 3-layer closure consisting of fascia lata or duragen, septal cartilage and mucosa, and for defects over 1 cm in size, a Haddad flap or a posterior septal nasal flap based on the nasoseptal artery of the SPA. In some cases, you can administer intrathecal fluorescein during the operation to identify the site of the defect or if multiple defects are suspected. However, patients should undergo allergy testing before this. Post-operative care should focus upon reducing the intracranial pressure, and as such, a 45-degree elevation of the head along with stool softeners is important to avoid straining. In recurrent cases, patients may require a lumbar drain, and they may also be treated with acetazolamide to reduce the intracranial pressures. Long term, a 10% reduction in weight is associated with a significant reduction in intracranial pressures, thus reducing the risk of further leaks. I hope you found this video useful. If so, please consider subscribing and let us know what you'd like us to cover next.